The MM014 study has been a two-part study, two cohorts, and really what the question that we've been trying to address is this notion of that we have to change classes of drugs at relapse. So the two dominant the drug classes that we've had up till now are proteasome inhibitors and IMiDs. Now we have the monoclonal antibodies, and in all three of those groups we have multiple drugs. In this study that I'm talking about, this is the use of pomalidomide in patients failing lenalidomide. I always hate it when I say it that way. It isn't the patients failing the lenalidomide, it's the lenalidomide failing the patients. There is an open question. When you go from lenalidomide to pomalidomide, do we see a significant compromise in the outcomes from pomalidomide? Well, the first cohort, which has been presented before, is patients who are progressing on lenalidomide going directly to pomalidomide and dexamethasone, and the response rates did not appear to be compromised at all by prior exposure, immediate prior exposure to lenalidomide. Well, in the theme of daratumumab, one of the most potent, if not the most potent, triplet combinations that we have is daratumumab, pomalidomide, and dexamethasone. Well, if a patient is on lenalidomide immediately prior, is the response rate to that very important triplet combination compromised? Well, this study shows that that does not appear to be the case. In fact, the response rate presented in this trial is the best that we've seen in that triplet combination. So it's important, maybe not transformative in how we think about these drugs, but this instinct that we all have. I mean, certainly community oncologists overwhelmingly, but even those of us who call ourselves myeloma experts, although I'm not sure what that means, the instinct is you're on lenalidomide, you need to go on to a different class of drugs. It just isn't true. There is no compromise. And I think that's important clinically and perhaps more important intellectually. I mean, why should it be? I mean, lenalidomide should compromise pomalidomide response subsequently, and it just doesn't. And we need to explain that.